GatewayC Bitesize, supporting earlier and faster cancer diagnosis, commissioned by the Greater Manchester Cancer Alliance.
FIT. Think A to G. Our specialist is Dr. Roger Prudham, consultant gastroenterologist.
A is for always use the correct container. Approximately 10% of FIT tests are incomplete because the container hasn't been labelled properly, so make sure you do that. The other thing we find is a problem with filling. It really is a very simple thing to do. The spatula here is just put into the sample, very small amount required, and placed securely back into the tube and then returned to the lab. So B is for bleeding. It is now well established through research that the FIT test can be used in patients who have rectal bleeding. Advice might be to do the test on a day when the patient isn't bleeding, or to find a portion of the stool where there isn't fresh blood. C is for colorectal cancer, and so we would ask that you only refer on the colorectal cancer pathway if the FIT test is positive, the exception being if there is an anal or rectal ulceration or mass. So if you can see or feel pathology around the anorectal area, then use the colorectal pathway even if the FIT test is negative. It follows then, what should you do if you have persistent symptoms or you have a patient who you feel may have cancer but has a negative FIT? The thing to do in that situation is ask yourself about the symptoms. If there is unexplained abdominal pain and weight loss but a negative FIT, then it seems reasonable to refer through the non-specific symptoms pathway to, for example, your local rapid diagnostic service. If, though, there are persistent lower GI symptoms and no other symptoms suggestive of cancer with a negative FIT, it seems reasonable to refer to the local gastroenterology service or colorectal service on an urgent elective pathway. Concern, therefore, may be about the false negative FITs. The false negative rate for FITs in the 60-year age group is 0.4%. So even in the situation where there is a negative FIT, the chances of the patient having a cancer is very small. It may then be reasonable after a period of time to perhaps reassess the patient or repeat the FIT, bearing in mind that the doubling time for colorectal cancer is around about 200 to 240 days. There is plenty of time because bowel cancer is so indolent to make a reassessment after a period of time. D is don't forget screening levels. The level that is accepted as being positive in the NHS bowel cancer screening program is 120 micrograms of hemoglobin per program of stool. Within labs and the convention across the country for symptomatic patients, that threshold is much, much lower. It's 10 micrograms per gram of stool. And that is because the question being asked is very different. The symptomatic patient is asking, have I got bowel cancer or not? And so we set the threshold very much lower to provide that assurance in that situation. And so the important thing to remember then is that a patient who's had a negative NHS bowel cancer screening program FIT test may still have bowel cancer, and it might be reasonable to do a symptomatic FIT if they've got unexplained ongoing bowel symptoms. E is for endoscopy. The FIT test allows us to prioritise patients very clearly from those that need colonic imaging or colonoscopy within 2 weeks, as opposed to those who can wait and have routine colonoscopy or colonic imaging. It is still the case that patients with persistent colorectal symptoms may have other pathology than cancer, and so we will still need to do colonoscopy, but we will prioritise those patients with a positive FIT because they are overwhelmingly much more likely to have an underlying bowel cancer. F is for FIT. This is so vital to us managing the front end of the colorectal pathway. Every effort should be made to get a FIT done. It is not always easy, we understand that. And we have some patients where no matter how hard you try, you still don't get that FIT done. What that does not do is allow secondary care to reject a referral. We will have to manage that patient, and if necessary, we've got staff who will work on the front end of pathways as soon as we receive a referral to encourage the FIT to get done. We have pathway navigators who do that. We have some colorectal specialist nurses who do that. Everyone will make every effort through things like text reminders, personal phone calls and encouragement to get the FIT done in every possible case. G is for the Greater Manchester Referral Proforma, and I would issue a special plea that you use the most up-to-date version of the form. That is the one that captures all of the intelligence that we talked about, all of the things in the fast facts that are important, and more importantly, it enables us to deal with that patient in the most responsive and patient-centered way.
Think A to G. A. Always use the correct container. B. Bleeding. C. Colorectal cancer risk. D. Don't forget screening levels. E. Endoscopy. F. Fit. G. Greater Manchester Referral Proforma.
GatewayC Bitesize, supporting earlier and faster cancer diagnosis, commissioned by the Greater Manchester Cancer Alliance.